Good afternoon, everyone. Thank you so much for joining the Clinical Research Center at University Hospitals, Cleveland, Ohio, for our Discover with UH webinar series, a monthly webinar series dedicated to exploring the intersection of clinical research and healthcare. I am Patricia Turstiniak, pronouns she, her, and will serve as your moderator for the day. This month, we turn our focus to exploring bone and joint health in honor of Bone and Joint Health Awareness Month, a health campaign intended to increase public awareness of the importance of prevention, management, and treatment of bone and joint conditions. And we're excited to be joined by our esteemed panel of physician scientists who will be talking with us about their work and research. I will provide the introductions of Dr. Raymond Liu and Dr. Marina Magray, followed by Dr. Liu's presentation. After his presentation, we will take questions from the audience at that time for his presentation and then move into Dr. Magray's presentation. So with that, let's begin. Raymond W. Liu, MD, is the Victor M. Goldberg Professor of Pediatric Orthopedics at Rainbow Babies and Children's Hospital in Cleveland, Ohio, with a specialization in hip and limb deformity. He completed his Pediatric Orthopedic Surgery Fellowship in San Diego, followed by a mini fellowship at the Paley Advanced Limb Lengthening Institute in West Palm Beach. Dr. Liu is a past president of the Limb Lengthening and Reconstruction Society, LLRS, and deputy editor of Hip and Lower Extremity at the Journal of Pediatric Orthopedics. He has over 100 PubMed-listed publications, and his research has received awards from the Pediatric Orthopedic Society of North America, LLRS, Scoliosis Research Society, American Academy of Pediatrics, European Pediatric Orthopedic Society, and International Congress on Early Onset Scoliosis. Dr. Liu has a strong passion for education. He has 3 times received the Outstanding Educator of the Year from Case Western Reserve University residents and was elected into the Alpha Omega Alpha Honor Society by Case Western Reserve medical students for his teaching. He has served as chair of the Education Committee for LLRS and is vice chair for the Board of Specialty Societies Education Committee. It is an honor to be here with you today. And our second panelist today is Dr. Marina Magray. She is the Roland Moskowitz Professor of Rheumatic Disease at Case Western Reserve University and Division of Chief Rheumatology at University Hospitals. Her research and clinical expertise focus on the measurement and management of spondyloarthritis, also known as SPA. The goal of her work is to improve outcomes among patients with axial spondyloarthritis. AxSPA is what we will refer to it as. She runs one of the unique SPA centers in North America and maintains a longitudinal SPA registry with over 300 patients. She is an invited member of the Assessment of Spondyloarthritis International Society, ASAS, an international society of experts in the field of SPA and group for research and assessment psoriasis and psoriatic arthritis, also known as GRAPPA. She is involved in collaborative projects with these organizations. The AxSPA Center at UH is part of the collaborative establishment of Center of Excellence named as Network for Research and Development in Spondyloarthritis. She has authored 70 manuscripts and over 100 abstracts. Again, thank you so much for spending time with us today. We've asked Dr. Liu and Dr. Magray to talk with us about recent research work that they're proud of and to shine light on the great work our researchers are doing to help shape the medical landscape. With that, I would like to invite Dr. Liu to the stage to present as he discussed skeletal maturity determination. For the audience, please feel free to drop your questions into the Q&A box at the bottom of your screen, and after his presentation, we will get to them. Thank you so much.
Thank you, Patricia. I'm going to go ahead and share my screen. And hopefully that looks right on everyone's screens.
Yes.
Okay. I appreciate the ability to talk about skeletal maturity determination with all of you. No disclosures are really relevant to this particular talk. So skeletal age is a concept of how fast someone matures. This is a plot of two children that are growing, and their age in years is on the bottom, and how much they're growing each year is plotted here. And you can see one of these boys develops a lot quicker than the other. And when we're deciding to do surgeries on these children, we need to know whether we have the blue curve or the red curve, because they're going to behave very differently. Just to visually show what this might look like, the blue curve may look like that much larger high school student than the red curve. Chronologic age has been proposed as being good enough. Is it good enough to make these determinations, and do we really need to worry about skeletal age? And this study showed that if you look at if you do your age predictions, you actually get the best prediction of growth if you use chronologic age. So that's just the age based on your birthday. That's what the Paley method here on the top used. And it had the best estimate overall, better than these other systems that use skeletal age. However, when you were around puberty, which is where most of our surgical decisions become important, then that flips, and the chronologic age is not as accurate, and the other systems become more accurate. So this is a study that was demonstrating the importance of skeletal age. Skeletal age is really special to us in Cleveland because a lot of the fundamental work was done here. So this is T. Wingate Todd, who helped collect the brush portion of the Fulton Brush collection. This was over 4,000 skeletons. 4,000 children who were very assessed in very standardized ways. One of the things this collection did was it defined how dental x-rays should be taken. So some of the most fundamental things, like the x-rays that everyone gets in when they go to the dentist's office, is based on this original work. This is a plot of how many children they had with different numbers of visits. And you can see that when you're talking about children who came in multiple times, 10, 11, 12 times, and had serial visits where they came in every year and had measurements of their bodies and x-rays of the left side of their body, there's only a certain number that had a large number. So it doesn't look like there's a lot, but then you have to remember there was 4,000 subjects. So even though it was a small percentage that had a lot of these visits, it equates to hundreds of children. And this allows us to look at things like the development of a child's hip. This is a series of x-rays of a normal, healthy child going from 4 to 14 years of age. And it is impossible to get this type of data today because now the risks of x-rays are well known. When this study was done, it was just not known. So this collection has data that no one else really has access to nowadays. And it was used to develop the Gruhl-Compile Atlas. So this is a system that's still used to this day. And the way it works is you look at x-rays of the left hand of a child and you compare it to the standards within that book, and you try and get the best comparison to decide what age the child's hand is. The problem is that there's a lot of subjectivity to it. There's also an issue that it's not like you can come in and they'll say your age is 13.7 years or 13.3 years. They just have standards every 6 months. So the best they can say is you're closest to a child that's 13 years, 6 months. But you may be 14, you may be 13. And so it's not very accurate. You also, oftentimes, these children that we need to decide when to do a surgery or what kind of surgery to do on, they oftentimes come in and they have an x-ray of their knee or their hip or some other part of their body, and you have to send them back to x-ray to get an x-ray of their hand. They get a charge on their bill, and they spend extra time in clinic. So it's really inconvenient. And so the system on the hand, although it's worked very well for decades, really needs an update. And so that's what we set out to do. The first thing we did was we needed to know, how do you actually judge a child's skeletal maturity? It's actually not the easiest thing to quantify. And working with my colleagues, we were able to look at the growth curves of children And this 0 point, this line over here is the peak height velocity. It's the time within a child's development when they grow the fastest. It's usually around 13 years in boys and 11 years in females. It's when you see children really sprout up and get taller very quickly. And this usually happens when they're about 90% of their final height. And so up to this point, peak height velocity was used as the standard for judging a child's skeletal maturity, but this study flipped it to 90% final height as being a better measurement. And when we did the curve shift and studied 90% final height, we now had this much tighter curve where if you knew when a child hits 90%, you can really guess the rest of their growth a lot more accurately. And so that was the idea behind switching over to 90% final height. We then studied, can we look at multiple sites? Can we get multiple parameters and get better resolution, get a better sense of how old the child really is? The line here again is peak height velocity. You can see there's a few data points before and after for both of these systems. But when we combine these two systems, now we have multiple combinations of points before and after the line, and we can give a much better and more accurate assessment of a child's skeletal maturity. Our next question was, can we use quantitative parameters? So a lot of what is used is qualitative, meaning you look at the shape of a bone or whether something's present or not. And it's a lot of stuff that, again, is very subjective. It's sometimes people won't agree on it. And it'd be nice if you could make actual measurements and make the distance between two lines and assess skeletal maturity that way. We have a second famous collection in Cleveland, housed at the Cleveland Museum of Natural History. This is the Hammond Todd collection, same T. Wingate Todd that helped do the brush collection. And this is 3,000 skeletons that are well preserved. Some of these skeletons are in children. And so these are three of the pediatric specimens from this collection, where we can see that the distance between the red and the green lines seems to become less as a child grows, and actually the red line goes below the green line with time. And this gave us a hint of a parameter that we could measure and plot against age. And you can see here this value versus age changes, meaning that it may be a really good parameter to judge a child's skeletal maturity. And we studied that, and this is one of our brush collection patients showing stereo x-rays of the same child. And you can see that the distance between these two lines, indicated by that little stubby vertical line there, increases as a child gets older. So this was indeed a useful parameter to judge skeletal maturity, and it gave us some more confidence that we could find some quantitative values to make a better skeletal maturity system. With all that background, we then pursued a really large study where we really got into the details on the knee. We felt that the knee was a good target because, again, a lot of the children who were worried about skeletal maturity already have an X-ray of their knee. And so we looked, and there were multiple systems described in the past, one by Pyle and Hoare that had stages for 4 different bones in the knee, and we incorporated that into our test. There was a group called Roach, Rayner, Thyssen that had actually isolated 36 characteristics of the knee, all of which had different scores that we put into our test. And then we were able to decrease this by 10 parameters because some of them just didn't work very well in our hands or didn't really apply to a child around puberty. And then we did the CPV is that measurement, that quantitative measurement that I showed earlier. And so we looked at all these parameters and we compared them between 2 of us and tried to decide, are they reproducible? Can 2 people use them well? And do they correlate with skeletal maturity? And with that, we were able to knock out an additional 12 parameters, these top 12, that just did not perform very well and weren't worth including in the overall test. But we kept the rest of the parameters. And so now we were able to test a large number of parameters and figure out what's the best subset of parameters to really guess a child's skeletal maturity. And this was our data with this. So when we looked at just demographics, just looking at chronologic age and associating with maturity, the R-squared is the amount of association. And it was actually pretty good with chronological age, which people know, it's about 0.84. When we looked at the quantitative measurement that we did, it was a little bit better. It got to 0.86. When we looked at Gruel Compile and Pile and Hoare, those two systems both performed a little bit higher, and they are both well-known systems. Gruel Compile for the hand, Pile Hoare for the knee. But finally, we identified a new system where we took the original Roche Rayner Thyssen system, which had 36 parameters, and we knocked it down to 7 using mathematical analysis with stepwise linear regression. We isolated the best parts of it and got a much better performing system. We then said, well, it performs well, but are we missing some information with the other parameters that we were testing? And when we looked at it, the new system that we had with just 7 parameters didn't really improve very much when we added back any of the other systems. So it was good. Just those 7 parameters is enough. These other parameters did not add much more. We wanted to make sure that the system works, even if the child turns their body in the X-ray machine. And so we were able to simulate rotated X-rays using CT scans of children. And we showed that even if they turned their body a fair amount, you would still get the same skeletal age. So this is resilient to position. And we know that children don't always position themselves consistently in X-ray machines. We want to see if this data worked for modern patients. This data from the Bolton brush is all 100 years old. And modern children have different hormonal factors and other factors that may make their skeletal maturity different. And sure enough, we did see some minor differences, and we were able to define them out, and in the future, we'll be able to correct for them. Finally, we want to make this practical. When you make a system with 7 different parameters, it's hard to get physicians to use it because it's complicated, it disrupts the workflow. And so we made a free mobile app that's available on Apple and Android that everyone can download if they wanted to. And the app, it lets you choose which body parts, so you can pick the knee, and then it'll go step by step through all the parameters. And for each one, it'll actually show you the different options that you can choose. You can even choose more examples and learn more about it so that you can make the best decision. And then it'll output a skeletal age. And this app's actually been downloaded over 1,000 times, which doesn't sound like a huge number until you think about the fact that in North America, we have about 2,000 pediatric orthopedic surgeons. So this app is being downloaded all around the world, but but 1,000 is a pretty big number in our field. We tested some of our colleagues within the system, all of whom had never used the system before, and we gave them 20 X-rays to grade. And we gave them no instructions. We didn't teach them how to use anything. We just said, download the app and the app will teach you. And when they did it, they actually had fairly good accuracy. After they did about 7 X-rays, they were hitting their stride and basically performing as well as they did by the end. And all throughout the study, they actually had fairly good accuracy. With this number around 0.25 years, that's considered very good for skeletal maturity estimation. So in the beginning, there was a little variety, as one would expect, as someone learns a new system, and then they became very consistent. So what's the future for us? Well, AI has impacted all of medicine, including our field. And right now, a physician has to look at an X-ray, input a bunch of parameters, and then is told the skeletal age. We would love it if they could just wave their phone in front of an X-ray, press a button, and then a computer makes the estimation more accurately and more quickly. And we are in the midst of collecting the necessary 9,000 plus X-rays that it would take to make such a system. And we're hoping that sometime in the near future, we will have this live and available to the world. So that's a whirlwind tour of skeletal maturity. Really appreciate everyone's attention. Happy to take any questions.
Well, thank you so much for going over that. A few things that stuck out to me was your desire to question, like, what, this historical knowledge. And I think we see that a lot in medicine, like, oh, this is the way, this is what we rely on. And then having that insight to say, oh, there might be better ways. How can we improve on that? I also appreciate how you compared like historical children bodies to modern children bodies. I think as parents and people who work with kids, like we might see that anecdotally, but to hear that from a physician that like validates, yeah, kids are different nowadays. We might not know why, but we can see it. And completely a huge achievement for getting 1,000 downloads on an app. You're 50%, you're halfway there. So kudos to all of that. I do have a few questions for you at this time. And again, anyone in the audience, please drop your questions in now. So just to zoom out a little bit, Dr. Liu, what led you to become involved in clinical research, in particular, looking at joints and bones and in with children? What was that turning point? If you can talk a little bit about your journey with us.
I think most as a medical student and as an orthopedic resident, there was a lot of encouragement to do research, and so I dutifully got involved in it and really learned to love it. When you do research, you get to, I mean, it's a lot of work to do the research, although sometimes it's really exciting to find what the answers to your questions, and then you get to go out into the world, around the country and around the world, and present this research to other people. And I've had conversations with people all around the world about this. That's been really, really fun. I remember once I was presenting this in Europe once, and I had people from Russia, people from Poland, all these other countries who saw these questions in such different ways and helped me understand my question even better. And being able to form those relationships has been really rewarding.
No, I'm sure. Thank you. We do have a couple of questions in the chat. One, do you think that this skeletal analysis system would have a use in forensics?
It potentially could. I know people use dental age and other things in forensics. At the Heyman Todd collection, there are a lot of people there that do forensic research that also research the bone collection, but I've never actually got into a discussion with them as to how useful this is for them. I think they have other methodologies for estimating a child's age that they prefer. One thing that's interesting is that something like dental, your dental development and your long bone development of your arms and legs, those are two different lineages of cells. One comes from they come from different parts from your fetal origins, so they may be a little bit different. And so for our purposes, in orthopedics, we're really interested in this, but for someone's overall age, they might find dental to be more useful.
Yep. And there is a follow-up question. I don't know if it's from the same person or someone else, but do you know if your app is predominantly or always used by pediatric doctors, or may it be possibly be used by forensic experts or other fields? So do you know who's using and downloading your app?
We don't have that level of detail. I feel like things like this, it's hard for people to find it. So we've noticed that like when we go to a meeting and we put up the QR code for our app, we see a spike like afterwards. You can visually see a spike in the downloads. So I'm assuming most of it is from us presenting it and then word of mouth, and the app is also written in our papers. And I don't know if a lot of forensic people read that. So I'd be really curious to see if people in forensics find this useful, but it's just a little bit outside my field.
Yep, I completely understand that. And then another question from the audience, do you plan on adopting this analysis system to other joints?
Yes, so I used the knee as an example, but we have written papers on the hip, the elbow, the wrist and hand, and the shoulder. We have one paper on the foot, but it hasn't, the foot has not been done as well as the other joints. So that is one on our target for the future. But yes, my goal is that orthopedic surgeons typically see children that have x-rays. And my goal is that no one ever has to be sent back to the x-ray machine to get a skeletal age radiograph. A lot of times this is $200 to $300 out of pocket for a family for information that already exists on another x-ray. And we just need to make that work for them.
So speaking of that and tying this into like clinical research, how do you talk to your patients? Or like, what are some reasons you may encourage a patient of yours to consider, to participate in research or in a clinical study?
So for all of this study, we're using pre-existing data, and so we're
Mhm.
not really enrolling them. But for studies that I have done that do involve patients, the ones I do are typically non-invasive, and so I'm basically telling them, hey, we're just giving you some surveys to better understand your condition, ask questions that we don't ask in clinic, and really make it so that people who have your problem will have better treatment in the future. A lot of the stuff I take care of is really rare, and the children understand that it's really rare, and they wish they could have more information about it. So to be able to give it to more people, a lot of them, especially the older kids, understand that and appreciate it.
Oh, yeah, well, we definitely appreciate you. Okay, so one last question, and on a personal note, so we get to know the researcher, the doctor behind the data. What is a podcast or a book that you can recommend to our audience today? What is something that you find inspiring or that you would just want other people to read or to listen to?
Oh, there's so many good things out there, but I think one book that really changed me was a book called The Obstacle is the Way. I believe it's Ryan Holiday. And what it's talking about is the idea of Stoicism. Stoicism is kind of like a more ancient philosophical belief system that you have no control over what other people do, of what happens externally. You just have the ability to control your own response to it. And I found that to be exceedingly helpful to help me better relate with other people, for me to deal with challenges. It really shows you how to get through hard times better. So I would highly recommend that book.
All right, so everyone in the audience, I hope you took that down. I'm always in search of those great books. That reminds me of a book. Can't think of the author right now, but it's What's in the Way is the Way. So very similar concept. Like it's not nothing is
Yes.
in the way. This is part of the
Yeah.
way. So we know you have another commitment. Thank you so much for spending your time with us today, and we wish you well and all your successes, and we hope more people download your app.
Thank you. Thank you for having me.
Thank you. Yep, absolutely. And at this time, if Dr. McGray, I see your camera is on, you can begin your presentation.
Well, first of all, I would like to thank, UH Research Institute and Patricia Yu for giving me this opportunity to give this talk. First and foremost, I consider myself a clinician. So I really feel honored and, humbled to be here today to give a researcher talk, because I entered my research career a little late because motherhood took some precedence. And I ended up for research here. So with that, I don't have any disclosures pertinent to this talk. As was mentioned earlier, my area of research and clinical focus is spondyloarthritis. So I'm going to give you a brief overview about what spondyloarthritis is. Spondyloarthritis, it encompasses a group of diseases that share etiopathogenesis, clinical features, and treatment options. So this is a bunch of diseases together. We call them spondyloarthritis. And spondy basically is like involvement of the skeleton, axial skeleton. Fits involvement of the axial skeleton, we call it axial spondyloarthritis, axial meaning back and sacroiliac joints. And if there is an involvement of peripheral skeleton, peripheral joints involvement, we call it peripheral spondyloarthritis. So broadly, axial spondyloarthritis, the prototypical disease for axial spondyloarthritis is ankylosing spondylitis. And the prototypical disease for peripheral spondyloarthritis is psoriatic arthritis. Then there are these diseases in between called reactive arthritis, arthritis associated with inflammatory bowel disease like Crohn's disease, ulcerative colitis. Undifferentiated, they can fit into both. They may have some features of axial, meaning mainly predominant involvement of the spine and sacroiliac joints, or they may have predominantly peripheral involvement. So these are a bunch of diseases together. We call them spondyloarthritis. And depending on whether there's like a radiographic involvement or not, we divide them into, now we divide axial spondyloarthritis, which mainly involves the back, into non-radiographic and radiographic. They're the two ends of the same spectrum. These are not two different diseases, but two ends of the same spectrum. Non-radiographic is those patients where we do not see changes in the SI joint on a radiograph, on an X-ray, and radiographic is where we see changes. Up till early 1970s, most of the classification criteria relied on changes on the radiograph. By the time we see changes on the radiograph, it's about 7 to 10 years, I would say. The patient has already had the disease. So in early 1970s, one of my mentors was here in Cleveland at Case doing research. He was taking these HLA-B27 positive, which is the gene MHC class 1 molecule, which is a risk factor for this disease, HLA-B27. He was looking at these HLA-B27 positive probands, the relatives of those patients who had ankylosing spondylitis. And what he found in those relatives was that these patients some of them were HLA-B27 positive. They did have symptoms suggesting that these people have axial pain, back pain, stiffness, but they did not have changes on the X-rays. So that's when this concept of non-radiographic kind of started to evolve. And then later in 2009, we developed classification criteria, were developed by ISAS, one of the organizations I'm part of, and they formally classified axial SpA into non-radiographic and radiographic axial spondyloarthritis. So chronic back pain is a very common symptom. It's the second most common symptom that a patient goes to see his primary care doctor. There was an Haynes study done in 2009, and that looked at the epidemiology of chronic back pain and inflammatory back pain in the United States. And what they found was about 20% of patients in this country will at some point will have chronic back pain. The prevalence was about 20% of chronic back pain. And out of those patients, about 5 to 6% may have inflammatory back pain. So what is inflammatory back pain? These are the patients who start with this back pain very early on, usually in their 20s or 30s. Pain is, associated with morning stiffness, lasting for about more than 30 minutes, like a couple hours of stiffness in the morning when they wake up. Pain gets better with activity. As the day goes by, they feel better, and they will often tell the physician that, I'm worse first thing in the morning when I get out of the bed. They're stiff in the morning, they're hurting. The pain may wake them up in the middle of the night, because be laying in the bed for a few hours, like sitting in a car on a long drive, they may feel this pain. And out of those patients, 5 to 6% who had features of inflammatory back pain, about 1.4% had axial spondyloarthritis. So the prevalence of axial spondyloarthritis is about 1.4%. And out of that, 5.5, half of them have ankylosing spondylitis, which is the radiographic axial SpA, where patients have already fused in their SI joints or in the back. Besides back pain, these patients can also have peripheral arthritis. They can have predominantly arthritis of the lower extremities, knees, hips, ankles. They develop tendonitis a lot, Achilles tendonitis. They have pain in the subbursas of their hips. Over time, they develop impaired spinal mobility. If you look at this patient, he has already hunched over. They can develop something called enthesitis, which is pain at the insertion of tendons and ligaments onto the bone. Achilles tendonitis is one of the common sites, heel pain in these patients. They can develop some extra-articular manifestations. Uveitis is pretty common, which is acute anterior uveitis. We get a lot of referrals from ophthalmologists. When the patient has acute anterior uveitis, they end up seeing painful red eyes. It's usually unilateral, self-limiting. They see an ophthalmologist. An ophthalmologist will check this gene, HLA-B27. If it comes back positive, they automatically send them to us to rule out this patient may also have axial spondyloarthritis. About 25 to 30% of these patients can have uveitis. They can also develop, it can also be a part of inflammatory bowel disease. Patients with Crohn's disease or ulcerative colitis, about 7 to 10% of those patients can also develop axial spondyloarthritis. 50% of these patients actually have subclinical bowel inflammation. They may not have overt Crohn's disease or ulcerative colitis, but they can still have inflammation in the bowel. And gut microbiome is now implicated, causing this inflammation and also in the etiopathogenesis of this disease. And about 10% of these patients can have psoriasis. And the hallmark of this disease is the sacroiliitis. If you look at this image here, they actually fuse their SI joints completely. So this is pretty advanced. Like this is grade 4 sacroiliitis. If I see a patient at this stage, then usually they have had the disease already for about 7 to 10 years. MRI of the SI joints has revolutionized early diagnosis. Now we rely on an MRI. If the SI joints are normal and our suspicion is high, we order an MRI of the SI joints. We rheumatologists, we rely a lot on imaging, so we will order an SI joint MRI looking for sacroiliitis. What we're basically ordering is 2 images. This is a STIR image, which is a fat suppressed. You don't see the subcutaneous fat here. This is a T1 where the fat is enhanced, and you are looking for bone marrow edema, this white shadow here on this T1, suggesting that this patient has inflammation around the SI joints, and then that helps us to make the diagnosis early on. Originally it was thought that this disease was, predominantly of men, because men tend to fuse and women don't. So women never fuse. So it was believed that this is more common in men, even though most autoimmune diseases are more common in women, like lupus is more common in women. RA may be roughly equally prevalent or maybe a little bit more common in women, but this was thought to be a disease of men. With the recognition of non-radiographic axial SpA, where the spine has not fused or SI joints have not fused, it's now found to be equally prevalent between women and men. And why women don't fuse, we don't know the answer. So there are some distinguishing features between men and women. Women tend to present more with neck pain compared to men. Men present mostly with lower back pain. Women tend to have more enthesitis, these tendinitis, and peripheral arthritis. They may also have widespread pain with it. The markers of inflammation are lower in women compared to men, and they tend to have inflammatory bowel disease. And some of these women get labeled with fibromyalgia because obviously the symptoms are, they have this tendinitis, tender points, they have neck pain, they may have chest wall pain, and they don't have changes on an X-ray, which somebody is looking for. Men tend to have more acute anterior uveitis and spinal radiographic progression. They are the ones who tend to fuse more than the women. Whether it's the hormones which prevent women from fusing, we still don't know the answer for that. And the disease is associated with a lot of common comorbidities. This is a meta-analysis that was done of 40 studies at a large sample size of about 120,000 patients. And what was found was that, these patients have a lot of comorbidities, very high risk of having hypertension, hyperlipidemia. They can tend to have depression, diabetes, obesity. So these patients have to be screened for all of these comorbidities regularly compared to general population. And what was also seen in these studies was that the comorbidities are higher in patients which have worse disease activity and functional status. So patients with bad disease tend to have more comorbid. So our job is to bring their disease under control. So with this background, what was the overview of my research goals? So I think the honor lies in my patients who actually push me every day to answer these questions. I focus on how can we diagnose this early on? What's the treatment of axial spondyloarthritis? We just completed a big international study called CLASSIC study, which was done all over the world, Europe and North America. University Hospital was one of the sites. We recruited one of the largest number of patients in it. And the purpose of the study is to see how can we classify this disease better? How can we find, clues where we can diagnose it better? So the results of the study are already being reviewed. It was 500 patients recruited from North America and 500 patients recruited from Europe. So the results are being reviewed. So hopefully by next year, we'll have the results out of the CLASSIC study. All our patients are very unique. I always tell this to the students and to the residents. It is, it's not one size that fits all. Every patient is unique. One patient may respond to the treatment, another may not respond to the treatment. And we really don't know what features are driving this. Are there any predictors of response? What's driving one patient to respond and not? So my part of my research is to identify biomarkers of disease activity and disease diagnosis in these patients so we can make better treatment decisions in these patients. And there are some gender and race-based differences in axial SpA, so I do some research in that and comorbidity burden in axial spondyloarthritis. When I first finished my fellowship, I got a small grant from Arthritis Foundation, and I looked at the prevalence of osteoporosis in ankylosing spondylitis. Now, as I mentioned earlier, ankylosing spondylitis was considered to be a disease of men only. So these were mostly men, and what we saw, the frequency of osteoporosis was very high among these patients. Patients greater than 50 years of age, frequency of osteoporosis was about 23%. And that of osteopenia was 41%. This is men, which usually don't get screened for osteoporosis. And among patients less than 50 years of age, the frequency of low bone mass was about 14.7%, close to 15%. So it's a unique disease. In this disease, you lose bone mass. At the same time, you form new bone to fuse your spine. Very, very paradoxical. Bone loss on one end, something is driving bone loss, and on the other hand, something is driving bone formation, and they fuse their back. So the study was basically looking at, can we use the DEXA scan, which we routinely use for screening for osteoporosis in these patients or not, since they get falsely elevated DEXA readings because of these extra bone that is formed there. So that was the reason I wanted to look into this study. I also looked at racial disparities, both in psoriatic arthritis and ankylosing spondylitis. Despite significant advances made in the treatment of these diseases, racial disparities in clinical outcomes still exist. So I used the Explorers database, which is a large database generated from Epic electronic medical records. And it was developed at Case. I think IBM now bought Explorers, but as Case faculty, we still have free access to it. So we looked at this it has millions and millions of patient records in it, real-time clinical records of these patients. And we looked at racial disparities between blacks and whites. And if you look at these, the blue bars are Caucasians and the green ones are African Americans. African Americans had higher risk of hypertension, diabetes, hyperlipidemia was roughly equal, obesity, coronary artery disease was slightly high, malignancy was little more in Caucasians, and so was osteoporosis. So this has to be kept in mind when we take care of these patients, that these patients are at high risk of comorbidities, but race plays a role in these diseases too. Whether African Americans have high disease activity which drives these comorbidities or not, that needs to be seen, or is it the genetic risk? As I mentioned earlier, gender also impacts the expression of this disease. Females tend not to fuse, males fuse. And Th17 cells have been recognized as a key cellular pathway for mediating this disease. And IL-17A cytokine is a key mediator of this disease. So what we did is we studied the transcriptomic of IL-17 producing cells in patients with AS. We tried to compare the differentially expressed genes in males and females, trying to see which genes may be responsible for causing this phenotypic difference between males and females. And we found there was about more than 2,000 genes that were differentially expressed between males and females. And males had high propensity for Th17 cells, which was seen by high levels of transcription factors associated with Th17 differentiation. We also found that TGF-beta, prostaglandin E2, S100 proteins. These S100 proteins were also differentially upregulated in men. There were two receptors which were downregulated in men, IL-23 receptor and IL-6 receptors. They were downregulated in men. At presently, we have cytokines available against IL-23 and IL-6, and both of those biologics did not work in AS. They work very good in RA. They worked good in psoriatic arthritis, but did not work in ankylosing spondylitis. It was coincidental. We saw that there were downregulated receptors in men. So this is the past research what I've done, and now currently what are we doing at University Hospital? Current spondyloarthritis research at University Hospital. We had some preliminary data. We had collected some data in 10 healthy controls and 24 patients with axial SpA, 10 females and 14 males, and we had found these S100A12 proteins. These are cytosolic calcium binding proteins. They regulate both intracellular and extracellular functions, inflammation in these patients, some other functions within the cell. They were significantly elevated in these patients. And S100A12 proteins have also been linked to atherogenesis, increased risk of atherosclerosis in the coronary arteries. There is a large cohort of Clarify cohort in the Cardiovascular Institute. They have 70,000 patients at University Hospital. These are patients which undergo coronary calcium scoring. And we looked at those that had a diagnosis of axial SpA and found about 29% of them had a coronary calcium score of greater than 100, suggesting that these people are at risk, increased risk of atherogenesis. So what we are doing now is we're trying to evaluate, trying to see if there is a correlation between S109 and S10812 proteins with this coronary calcium scoring, and also exploring some other inflammatory activation using sensitive cytokine analytic pathways in these patients. Another study we're doing in psoriatic arthritis called axial involvement in psoriatic arthritis. Psoriatic arthritis is a very heterogeneous disease. It can involve peripheral joints. It can mimic rheumatoid arthritis. It can involve, along with peripheral joints, it can involve spine. You can just have, what we call oligoarticular involvement, just less than 4 joints could be involved. It can present as only people having just enthesial inflammation. So it's very unique. So one thing which is not clear about is how many patients with psoriatic arthritis get axial involvement. Is axial involvement different in psoriatic arthritis than what we see in ankylosing spondylitis? That's another question. So this study, which is another international study, so it is sponsored by GRAPPA. The aim is to systematically study clinical and imaging manifestation indicative of axial SpA involvement in patients with psoriatic arthritis. So we could develop uniform classification criteria and nomenclature for axial SpA, because most patients with axial spondyloarthritis, they start early on, young patients, 20, 30, but for patients with psoriatic, may have spine involvement later in age. They may not have classic sacroiliitis, what we see in patients with the ankylosing spondylitis. So this study will be able to answer those questions for us. We are also doing a clinical trial with the agent is the deucravacitinib, which is a TYK2 inhibitor for patients with active psoriatic arthritis. We are also doing another study, which is not part of axial SpA, which is in knee osteoarthritis, because knee osteoarthritis is another very common problem throughout the world. And this is looking about trying to compare different treatments with the aim of reducing knee pain and improving function for those patients who have advanced knee osteoarthritis and are not candidates for knee replacements. I would end by thanking our research team here, our coordinator, Elise Boyd, Luke Molitor, some of my colleagues, co-investigators, and the support from UH Research Corps. And thank you so much for paying attention, and we are ready for any questions.
Well, thank you so much. I am completely blown away with how much depth you were able to provide in a short amount of time. And I know people with axial SpA probably really appreciate all of your work. When I was preparing for this, I found out there are support groups, and I learned a lot over the past month or so. I do want to point out a few things that I have learned. I appreciate the context you provided of how this groups in with other health conditions, especially us understanding chronic low back pain and how prevalent that is in the US. And then some of these differences with racial disparities as we look at comorbidities, because we know a lot of people focus on chronic disease, and then the difference of how it presents differently in men and women. So thank you. Thank you. You've given me a lot to digest here. I do want to get to a question that's in the chat. I'm going to read it here in live time. This person says they had juvenile rheumatoid arthritis treated with high doses of aspirin. They have psoriasis, went into remission per se after menopause. My knees and wrist and back have pain. I have now osteoarthritis. I had a bone density scan with a high fracture risk, but mild osteopenia. Could this be what you are describing? Steroids have been the only real help for me. I have been told I don't have inflammatory arthritis as of my latest testing, just osteoarthritis. And I'm sure you can only provide so much information, in this context. Anything you can add would be helpful to this audience member.
First of all, it's a double whammy, juvenile RA, and then later developed psoriasis. Now, I don't know if the JRA was JRA or was that maybe a psoriatic to begin with without skin involvement at younger age and came back later. That sometimes happens. You can get a small percentage of people can get joint involvement first before psoriasis shows up. Now, at this age, they're telling, osteoarthritis. Now, we don't use steroids. We don't use steroids either for axial spondyloarthritis or psoriatic arthritis because if you use high dose of steroids for psoriatic arthritis, there is a risk of making the psoriatic rash go bad. So the rash can flare with steroids. And with ankylosing spondylitis, there is no data that it helps. Now, and so same is, for osteoarthritis, steroids do have some anti-inflammatory effect. It will help if a patient takes it, but the problem is you can stay on it long term. And OA doesn't go away. It's not going to go away by taking, we even the recommendations nowadays for treating rheumatoid arthritis with steroids have been changed because we have so many new treatments for our rheumatoid arthritis, biologics, DMARDs that nobody wants to stay on steroids because of the lot of comorbidities associated with taking steroids. So whether, I wouldn't be able to tell you what kind of arthritis is causing pain now, unless I see as a patient what's going on. Is it OA that's predominantly causing the symptoms, or is it the psoriatic arthritis? Because we don't see much osteoarthritis in the wrists unless there is something called calcium pyrophosphate, which is another disease, can cause osteoarthritis in the wrists along with, inflammations. And then sometimes that can mimic rheumatoid. So I would suggest that it may be a good idea to see a rheumatologist so that they can go in depth into this.
Yep, thank you. Thank you. And I'm sure that audience member really appreciates your insight and wisdom here. So a similar question that I asked Dr. Liu, just to kind of broaden the field a little bit, what made you get interested in this particular field? Was there something in your medical or in your career journey that excited you, or what was that? If you can give us a little information there.
As I told you earlier, Patricia, when I finished my residency, I had one kid, and then I was pregnant and was going to have another kid, and my husband was doing a fellowship, and I told him, hey, I don't want to go for a fellowship now because one of us has to be home in the evenings. Otherwise, the kids are going to say, where are the parents? So I ended up working as an internist for 5-6 years. Then when my husband was done and he was settled after his training and was working, and I said, now I want to do a fellowship. So I went back to the Cleveland Clinic where I had done my residency to the fellowship. And when I was graduating, Gary Hoffman, he was the chair of rheumatology at Cleveland Clinic, and he was also my mentor. And he was like, why don't you stay here, Maureen, and work with us? And the conferences used to be in the morning at 7 o'clock every day. And I said, no, Gary, my kids are now going to start school and we live on the west side of the town. I don't think I will ever make it to the conferences here at 7. So I need to go and find a job on the west side of the town. So I ended up going to Metro Health, which is like only 10 minutes away from my kids' school. So, well, I don't know whether they had it or it's like, serendipity, whatever. One of the faculty members there actually has ankylosing spondylitis and was doing research in AS. So it was like he's very renowned all over the world, being a patient and a physician. So he was doing research. So I went there and I was like, you know what? They had a large patient population of these patients coming from all over the world. So I was like young and I was like, you know what, why don't we develop this database for you? Why don't I develop a registry for you? And I started working with these patients and developing, and that's how I ended up doing spondyloarthritis.
Thank you. I just love hearing people's stories, and whether if it's serendipity or something that happens along the way. Thank you so much. We probably have time for 1 or 2 more questions. So I know you talked about like the racial disparities. What else can you share about that when it comes to the comorbidities that you see? Have you worked with like other researchers trying to address that, or anything you can expand upon would be appreciative.
You know, HLA-B27 is the gene that increases the risk of ankylosing spondylitis. And now the prevalence of HLA-B27 gene in United States is about, in general population is about, 5 to 6% of these, 7% people will have it, even without having the disease. So, and this gene is more prevalent in Caucasians. African Americans don't carry this gene. So people thought that Blacks will not get this disease, but lo and behold, they do get AS, and without the gene. So that means HLA-B27 alone is not responsible for this disease. There are some other genes driving it. And GWAS studies have shown there's like 100 genes, other genes that may be contributing. So this overall concept was originally it was thought that Black people, women don't have it. So often they get missed. Because people now, they say your eyes see what your mind knows. So your mind is programmed that this is more common in white men. It's a disease of white men. So often it got missed in women and Black people. So, and disease severity was higher in them, whether it's genetically that they have genetic risk for high disease. Because when I was at Metro in our database there, about 25% of our patients were Blacks. We were under the largest centers in the world with Black people, other than people who are working on it in Africa, that had Black people with the disease. Because I saw a lot of comorbidities in these patients, even at the local level. And then that was kind of generated my interest, that I used to see these people with high disease activity, high C-reactive proteins, high. So when I saw that, I was like, we need to look into it, and what would be a large database, clinical database, where we can see if there really is a difference. And that's when we studied Explorer's database.
Thank you. All right, so this is going to be our last question from the audience. Is there any research on any holistic or nutritional changes people can make to decrease symptoms associated with the disease?
Very, very, very good question, because this is often asking, and because a lot of scientific data is coming that gut microbiome dictates a lot of this inflammation. So what we eat dictates how much inflamed we are. And so there's a lot of studies going on, people trying to use medications and trying to see what can we do to change our diet that can reduce inflammation. We do recommend to people to take antioxidants, particularly if somebody has osteoarthritis. We do say they need to take antioxidants like fish oil, green tea, turmeric, that kind of stuff. And whether there is whether we have studies to show that it really will halt, we don't know that yet. But recommendation is to eat healthy, exercise. Exercise is a big component, and quit smoking. Smoking is a big no-no. And whether it's rheumatoid arthritis, ankylosing spondylitis, smoking is a big risk factor for this disease to flare. Even what we've been reading, and some scientists working on it, is that they think that perpetual antigenic, the smoke may have perpetual antigenic stimulation. It is something in the smoke which is causing this thing, and you may have the gene and you would have probably never gotten the disease, but you started smoking and that triggered it to become flared or become over. So in terms of diet, we don't have any specific diet, but we often recommend to take some antioxidants in diet.
Well, thank you. And I'm sure if we had more time, we can keep talking about this. Thank you so much for joining us. I know Dr. Liu had to leave early, but thank you, Dr. McGray, for taking the time to talk with us about your work, the importance of research, and how all of this really helps play a role in shaping medicine and improving standards of care.